Welcome to this show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about DVT. When I left off last week, we had just evaluated a patient for the possibility of deep vein thrombophlebitis. I did the history, the physical exam, the evaluation. We did an ultrasound that showed the patient will indeed have a clot in the lower extremities. And I explained the differences between the clot in the venous system versus a clot in the arterial system. The clot in the venous system is called a red thrombus. The clot in the arterial system is called a white thrombus. There are major differences in the fact that the clot in the venous system has basically red blood cell and debris, very, very few platelets. On the other hand, the clot in the high flow system, namely the arterial system, is made up mainly of white blood cell and platelet. Mainly white blood cell and platelet and a few debris. Very big difference because the treatment is different. Now, and of course the evaluation is also different. Now last week I began to treat the patient with heparin. I get to that point. The reason why you have to do so, furthermore, you must make the diagnosis promptly. And because if you don't make the diagnosis promptly, the patient wind up with what's called post-phlebitic syndrome. Namely, if the patient had a leg that was swollen, let's say for 2-3 weeks, he or she ignored it, and or somebody didn't pay close attention to it. Now, at that point, the clot has already consolidated, and you can't dissolve it. So you can treat it, but you can't dissolve it fully. So the patient's leg is going to remain swollen for the rest of life, period. Because once that clot becomes consolidated inside the vein, you can't dissolve it completely after that. So you have a very bad-looking situation. We have post-phlebitic syndrome, with someone have a completely swollen lower legs for life. So you have to avoid that. And the patients has to know, as soon as they see swelling leg that has some tenderness in it, they must call the doctor to let him or know right away what's going on, and or show up in the emergency room, the nearest emergency room at the nearest hospital, so this thing can be taken care of quickly. So the treatment that I started to talk about last week, of course, was heparinization. You have to be very careful. If you're going to use heparin to treat patients, for whatever reason you're going to use the heparin, you better be sure you understand what heparin is all about. It is very fantastic medication, but can cause major problem. People talk about bleeding. Yes, bleeding is the number one problem, but that's not the only problem. Because when you give somebody heparin, there are many, many things that can happen. Number one, the patient may not respond to the heparin. So you keep pushing the dose. That could be very dangerous. Not only the bleeding, the truth is, pushing the dose is not what's causing the bleeding, because as long as the patient's factors, the intrinsic factors become eliminated, if the patient is going to bleed for whatever reason, he or she's going to bleed anyway. So that being said, if you're having difficulty raising the partial thromboplastin time because somebody is on heparin, the red flag should raise right away that the patient may have a problem. That problem could very well be, number one, it could be platelet factor 2 abnormality, because platelet factor 2 is secreted by the clot itself, believe it or not, and it is an anti-heparin material. So you could not heparinize the patient because the platelet factor 2 is an anti-heparin material. So you must know about that so that you don't keep raising the dose every day. In the meantime, the patient is not being treated because the clot is not being dissolved because you keep raising the heparin and it's not going anywhere. You must know enough about it to know that there's something called platelet factor 4 that is being secreted by the clot themselves, and then that's an anti-heparin substance. That's number one point. The number one point that you need to know, and please pay close attention to this because this is serious business. This is not easily obtained information that I'm giving you, okay? Some of you, this is the first time you're hearing about platelet factor 4, okay? be careful. This is very serious stuff. Somebody's life is in your hand. You must know this stuff, or else call somebody who knows to help you to take care of the patient. The next problem, heparin cannot work under any set of circumstances is you don't have ample amount of antithrombin 3. So another thing to evaluate, and you cannot evaluate antithrombin 3 if you didn't do it before you start the heparin. You understand that? So you must have done your profile before to know that if because heparin is not an anticoagulant per se. Heparin really, because without a proper amount of antithrombin 3, heparin is useless. It won't work. So if you're having a problem raising the partial thrombin response time, take a look at the antithrombin 3 level. If your antithrombin 3 level is low, the heparin will not work because it needs the substrate, which is antithrombin 3, in order for it to work. You understand that? And if you are in a position where you're not able to get Lovenox, you're not able to get other material that you can use to treat the clot, then you must then do what you can to infuse the patient with fresh frozen plasma. By giving the patient fresh frozen plasma, keeping in mind the possibility of infection, etc., then you are repleting the level of antithrombin 3, then you're going to make the heparin work that way, okay? Because, you know, this show goes all over the world, and not every place around the world where people have the access to all the fancy stuff. Something as simple as infusing the patient with fresh frozen plasma will raise the level of antithrombin 3 because fresh frozen plasma is loaded with antithrombin 3, okay? That will enable the heparin to work. So those are the 2 points you need to keep in mind. The third extremely crucial point to keep in mind when you're going to give somebody heparin, there's a condition called heparin-induced thrombocytopenia, okay? Heparin-induced thrombocytopenia. This is whereby the heparin causes an antibody to be developed within the heparin and the platelet, and then you have an antibody that's preventing, okay, that's causing this problem. And then therefore, then you're dropping your level of platelet. You're dropping your level of platelet because you just developed heparin-induced thrombocytopenia because it's an antigen-antibody reaction. So when you're giving somebody heparin, you do your complete blood count. Pay close attention to the baseline platelet count. The baseline platelet count is normal is from 140 to 400,000. Okay, take a piece of paper and a pen. If you start the patient on heparin on Monday, you're going to do a CBC Tuesday morning to make sure that the hematocrit didn't drop, i.e. the patient didn't bleed. But in addition to that, you want to take a look at the platelet. If the platelet count was 400,000 on Monday and Tuesday morning, it dropped to 200,000, which is within the normal range, but that's a red flag. 50%, if you drop your platelet count by 50% the next day, right away you are entering into the territory of platelet-induced, heparin-induced thrombocytopenia. Let me repeat that. Platelet count, 400,000 on Monday before you start the heparin. You start the patient on the heparin. Tuesday morning, the normal thing to do is to do a blood count to make sure the patient didn't bleed. But there's something more than just bleeding. Take a look at the platelet count. Because if the platelet drop to 200,000, even though it's within the normal range, that 50% drop, that is the first red flag. You are now developing heparin-induced thrombocytopenia, which means that you must quickly stop the heparin and send the antigen antibody test to the lab. That take 2 weeks to come back. You don't have time. You have to take care of the patient within that 2 weeks. But you do it for the purpose of doing it. And then you have to change your modality of treatment. Just keep that in mind, okay? Because if you don't, then you're going to run into major, not minor, major catastrophic problem that include clotting. That's right. Now you understand, yes, heparin can cause bleeding, but heparin also can cause clotting, because heparin-induced thrombocytopenia is not a bleeding necessarily problem, it's also a clotting problem associated with it. How about that? Super, super important. And if you do develop heparin-induced thrombocytopenia, The last thing in this world you want to do is to start that patient on Coumadin. Do not. You cannot touch someone who you just diagnosed with heparin-induced thrombocytopenia with Coumadin. If you do, you're just going to develop, in a few days, Coumadin-associated necrosis. How about that? Any organ in the body, inside or out, can necrose, and it has to be resected surgically. Can you imagine that? It's a crisis. Don't do it. There are other things to do. I'll tell you what they are. If you diagnose heparin-induced thrombocytopenia, you have 2 weeks to wait for the result to come back. That's too long. You have to use your judgment. The platelet can't keep going down. That's heparin-induced thrombocytopenia. You must not, let me repeat, you must not touch that patient with Coumadin. If you do, there's a condition called Coumadin-associated necrosis. One organ, one part, the leg, the breast, or whatever, is going to necrose. That's a catastrophe. You don't want that. Okay, what do you do then? Well, the easiest thing to do, frankly, nowadays, you could give the patient Lovenox, because Lovenox is very rarely associated with heparin-induced thrombocytopenia. Very rarely. So you could switch to Lovenox right away, treat the clot that way. In fact, nowadays, I know I haven't used heparin in so long, because nowadays I just put them on Lovenox right away, right off the bat. I did my workup, I started them, because I stay away from that heparin. By the way, if a patient develops heparin-induced thrombocytopenia, that patient must never again, for the rest of his or her life, be touched with heparin in any quantity. Even the little bit of heparin that is used to flush the IV line cannot do that. Cannot do that. So all my patients who have had that problem, they must tell the treating doctors or nurse practitioner or whatever, they are allergic to heparin. That's easier to, it's an easier word to use. You're allergic to, they won't touch you with heparin. You cannot. If you do, you're going to precipitate the same problem all over again. Now that I said that to you, there's another medication. If the patient is very sick, you don't want to, or they can't afford it, or whatever the situation in the hospital, you don't want to use Lovenox. There's a very important intravenous medication called agatrobin. You could treat the patient with agatrobin intravenously to dissolve the clot, whatever. And then once the patient is stable, you could either switch the patient over to Lovenox if you want to, and or give the patient a factor 10 inhibitor such as Eliquis or Xarelto or whatever. Okay. Nowadays, as a matter of fact, it is now recommended you could actually treat the DVT de novo as you start out with factor 10 inhibitor. That's being done as well. I don't do it that way. I really like to dissolve the clot as much as I can, just to prevent post-phlebitic syndrome as much as I can, and then I switch the patient. I send the patient home with, so I start the patient on Xarelto or Eliquis. Xarelto is easier, it's once a day, but some people cannot afford them. They're very expensive, so therefore you give them, Lovenox is cheaper than all the factor 10 inhibitors. Okay, I send them on Lovenox. So this is how we go about treating DVTs. And you have to remember, deep vein thrombotic phlebitis does not only occur in the lower extremities, it can occur in the arm. I have 2 patients that I'm treating actively right now. One patient developed DVT in the jugular vein. How about that? Jugular vein. In jugular vein. Another patient has a DVT in the splenic vein. So I'm actively treating these patients, okay? So I know both of these patients I diagnosed, no big deal, 1, 2, 3, they're diagnosed and they're being treated. So anywhere, any place in the venous system, you could develop a clot, and that clot must be treated. You can't treat a clot that's in the lower leg of somebody who has a DVT with aspirin. It makes no sense. It makes no sense because there is not enough platelet. In order for you to dissolve a clot with aspirin, you have to have the presence of platelet in ample quantity. I'm here to tell you, no matter what you may have heard, it is nonsense. You don't have enough platelet and a red thrombus. You just don't, period. So therefore, don't bother to waste your time risking bleeding for no reason. It's not going to work, okay? People who think it's working, they're just fooling you. It's not working. Now, that as you treat the DVT for 12 weeks. If it is a DVT that is, you can't find the source of it, but most of the time, almost 100% of the time, I would say maybe 90+% of the time, when somebody has a DVT, there's a reason for it. Almost always there's a thrombophilia. And look at the list of the thrombophilias. Just from here to there, these are the different things that can cause somebody to clot, okay? Now, I went over those, I'm not gonna go over them again. In addition to that, it's very important because if somebody has a thrombophilia, you diagnose it for whatever reason, they never clotted, you don't treat them for the clot because they never clotted. However, you prophylax them for the thrombophilia if they're traveling long distances by car, by plane, or what have you. Or if they're laying in the bed for long periods of time in the hospital, they're sick or whatever, you prophylax them. If they clot once, not only that you have to treat the clot, they must remain anticoagulated for life. That's right. If they clot once, if they never clot, we prophylax them. But if they clot once, you treat the clot. A DVT is treated for 12 weeks. 12 weeks. After the 12 weeks, they have to remain on a prophylactic dose for life. That's very, very important. And there's a long list of do's and don't do's. And all the don't do's have to do with hormonal situation. Okay? If a female of childbearing age who has thrombophilia cannot take birth control pill or any pill that has estrogen like medication in it, any substance. If they do, she's going to clot. Then if a man cannot take any, in addition to the female of childbearing age, postmenopausal female, because they have the postmenopausal symptom, which can be devastating according to these ladies, very annoying. They also cannot take any of those hormones that are being prescribed to alleviate the symptoms of postmenopausal symptoms. They cannot touch it. If they do, they're going to clot. Okay? Now, and a man, similar situation. If the man has a thrombophilia, he cannot go near any hormone that I use either to treat prostate issues and or to improve sexual potency. If they do, they're going to clot. So those are the don't. Okay? And if the man has a thrombophilia, he knows that he has thrombophilia, he's going to have prostate surgery. The urologist is going to give him some hormone to try to shrink the size of the prostate. The primary care physician or the oncologist must give the patient either Xarelto or Eliquis or something like that for the period of time that he is on the hormone. Otherwise, he is going to clot. Way before he gets his prostate taken out, he's likely to clot, and you don't want that. And the clot may not be simple. There's not such thing as a simple clot. So these are the things that you must know, okay? Now that I've given you a broad evaluation, you have a broad idea what DVTs are, how you treat them, the do's and the don't, and so on. If the patient have a DVT, well then they are at risk to develop the next problem that I'm going to talk to you about, which is pulmonary embolism. Pulmonary embolism is extremely common, more common than people understand or knows, because most of the time they found at autopsy, they found that the patient had pulmonary emboli and nobody knew anything about it. Because as I told you in my previous shows, very recently, 2018, two separate patients of mine, I decided to admit to the hospital because they have DVTs, and it's better for me to evaluate them and treat them appropriately under my control inside a hospital. Absolutely zero symptoms of pulmonary embolism. No cardiovascular, no pulmonary symptom, which is shortness of breath, chest pain, tachycardia, fever, none of that. But I decided on my own, based on experience, as I'm going to evaluate them, let me do a CT angio, which is a test that we do to see if there's a clot in the lung. In the old days, we used to do lung scan. Now, CT angio is quicker to get and it's more accurate. Both patients that I have admitted to the hospital with clots in the legs, both patients had clot in both lungs. Let me repeat that. Both patients with no cardiopulmonary symptom that I admitted last year, right here, in the hospital on Davis Avenue, with no symptom. As I'm writing the orders to admit the patient, I decided, you know what? Right, I'm doing a chest x-ray, but let me also do a CT angio. Based on experience, both patients, one a woman, the other one a man, had clot in both lungs, bilateral pulmonary emboli, with no symptom. How about that? Okay? So that's what I said before, and I'll say it again. To practice high power, high class academic clinical medicine, you must have knowledge, you must have experience, and you must have judgment. Those are the three things that are necessary. And I just tell you, okay, clot in the lung with no symptom. 2 patients in 1 year, in one hospital. Okay? So, pulmonary embolism. What is a pulmonary embolism? Well, a pulmonary embolism is a clot that dislodged from somewhere and it finds itself in the lung. It's quite common. Hundreds of thousands of people develop pulmonary emboli in this country every year. And thousands of people die because of it. Some of them die acutely because when the clot dislodges from wherever it's dislodging from, the leg or the arm or in any venous system, it could lodge itself right in the area between the left lung and the right lung. That's called a saddle embolism. A saddle embolism causes death within seconds. Just like that. If somebody hits you over the head and you drop, you die. That's it. So it's very important. However, the vast majority of the time, people have symptoms. The symptoms include shortness of breath, chest pain, fast heart rate, fever, tiredness. Something bad is happening. They start sweating without any explanation, without any effort. Those are the symptoms that you look out for when somebody presents with pulmonary emboli. Sometimes they have no symptoms, as I just described to you. So what do? Well, take a history from the patient. Are you taking any over-the-counter hormone? Because nowadays this is the danger, that people now can go over the counter and buy these things. One of the patients that I had last year, she actually was taking this stuff over the counter for postmenopausal symptoms. I knew nothing about it. And she almost lost her life because of that. And as I said before, many years ago, before my hair was gray, I was teaching at North Central Bronx in the Bronx. I show up one morning, my team, a couple of intern residents, about 6 or 8 of us, was presenting cases to me. One of the patients that was presented was a 15-year-old young lady, came in aphasic and paralyzed from one side because it turns out that she was on birth control pill. She will never speak again, never walk again, 15 years old. I'll never forget that case, okay? So this is serious business. Serious business. This is serious business. And this is the stuff, this is up to date. Look at the list. Every single one of these things represent the thrombophilia. Either the level is too high or too low. That renders the blood too thick. And when you take any kind of hormonal substance, it precipitates it just like that. In addition to that, any type of cancer, doesn't matter, either hematological cancer or solid cancer of any type, melanoma, you just name it, multiple myeloma, it never matter what it is. And the patient, in fact, can develop Trousseau syndrome. Trousseau syndrome was first described by Dr. Trousseau, who was a French surgeon in the 1800s, who diagnosed a patient with cancer of the pancreas, who developed a clot because of the cancer of the pancreas. And the patient, of course, died. And sadly, Dr. Trousseau himself subsequently developed Trousseau syndrome, the syndrome that he described, and died because of cancer of the stomach. Dr. Trousseau did not die of cancer of the pancreas. Dr. Trousseau died of cancer of the stomach, secondary to the syndrome that he himself had described. So every time you see somebody with a clot, unless you could show that in fact was taking a hormone or whatever, you must, without any doubt, have in the back of your mind, sometime in front of your head, to look for a cancer. And there's some key to the locks that can tell you if somebody has cancer if they don't. And I'm not going to sit here and tell you everything that I know, but I will tell you that as part of your evaluation, there are certain tests. If you know what they are, you could order them, and right away that will tell you whether the patient have or doesn't have certain form of cancer. I'll give you one little hint. Suppose somebody has a lymphoproliferative disease. Just to be fair to you, you do an LDH, lactate dehydrogenase. What's the important? You cannot have a lymphoproliferative disease and have a normal LDH. You say, well, how so? Well, because all these cells grew via the anaerobic pathway, and the end product of the anaerobic pathway is lactate dehydrogenase, LDH. How about that? I'm just giving you one little example. I have a dozen more I can give you. Keep that in your pocket. Right away, you know that patient. There are a lot of things that can co-elevate LDH, but if you have a lymphoproliferative disease, your LDH will be up. And if the LDH is negative, move on. Don't even stop that. It's not the lymphoproliferative cancer that's causing the clot. Listen, I'm going to stop here. Next week, I'll continue to talk about pulmonary embolism. Until such time, keep watching the show. It's Dr. Alcena saying so long and bye-bye.